All right, let's get down to nuts and bolts. I've spoken about theoretical concepts, but I'd really like to talk to you now about things that you can do practically to prevent awareness, because I'm sure you're really interested in the neurobiology, but what you really want to do as a practicing clinician is to think about how you can prevent your patients from having a devastating complication, because that's really important and that's something that you can implement now. So, simplistically, there are a few things that are well worth doing. The one is to target an adequate dose. So if you think that 50% of patients might require a particular dose or concentration of anesthetic to make them unaware, you should exceed that dose by a good margin so that you have enough safety to ensure that the patients are unaware. And we think of that in terms of MAC equivalents for volatile agents, so as a fraction of MAC. What fraction of MAC would be likely to prevent the overwhelming majority of patients from experiencing intraoperative awareness? Very importantly, we should be assessing purposeful movement. You can't do that if you paralyze your patients pharmacologically. So it's really, really important to try to limit the amount of muscle relaxants that you administer and only to give what is absolutely required for the surgery. For example, if you think about heart surgery, yes, the surgeon has to operate on a paralyzed heart, but it is not rocuronium that paralyzes the heart, it's potassium. So why are we piling on huge amounts of rocuronium for heart surgery when really all we need to do is to ensure that our patients are anesthetized and they could be getting potassium with the cardioplegia to paralyze the heart. So often we're unnecessarily administering too much muscle relaxants, and you can hear from the tone of my voice that this is something about which I feel somewhat passionate. The other thing that I'm going to be talking a bit about is monitoring the brain. We've been in this business for about 150 years as anesthesiologists, and we're all excited about monitoring the cardiorespiratory system with a whole range of monitors, and yet our emphasis on monitoring the brain and the nervous system, which is indeed the target organ of general anesthesia, has been sadly neglected. This is something that I would like to see changed in future, and I think that in future all general anesthetics will have some form of brain monitoring. The problem is which form, and this leads to sparks flying and nobody being able to agree. Again, going back to the review article that we published in Anesthesiology, Mashur, Orser, and myself, we did have a checklist of some very practical tips of things that you can do to prevent intraoperative awareness. And I would like to highlight some of these. The one is a point I've already mentioned. Minimize the amount of muscle relaxants that you're using. It is likely, although not definite, that if you have a patient who's experiencing intraoperative awareness and they can move, they will move. I say that this is not definitely the case because, for example, in an article published by Sandon and others in The Lancet, they reported that there were patients who had intraoperative awareness who were not pharmacologically paralyzed. So it is possible, even without pharmacological paralysis, that patients may choose not to move or indeed be unable to move. And there are correlates of this in psychiatry or even in sleep. If you think about REM sleep, we're not pharmacologically paralyzed, but we're also unable to move. So it is possible that, for example, with propofol, or dexmedetomidine, one of the volatile agents, that we might actually be in a state of not being able to move, or somehow our brain not being able to effectively send a signal to our body to move. So I wouldn't say that it's 100% guarantee, but certainly the literature supports the fact that patients who are not paralyzed have a much lower incidence of intraoperative awareness and have less traumatic intraoperative awareness. So those are important points to mention. There is now overwhelming evidence that there is a higher incidence of awareness with total intravenous anesthesia compared with a potent volatile anesthetic agent like isoflurane, sevoflurane, or desflurane. So all things being equal, I think that there is a strong reason to consider using a potent inhaled anesthetic agent and to administer at least 0.5 to 0.7 MAC, age adjusted of course, and also to set an alarm or an alert for a low MAC concentration, and that's something I will come back to. If you are paralyzing somebody, I strongly recommend a safety cushion. In other words, if you weren't going to paralyze them and you were going to give them 0.7 MAC and you're paralyzing them, give them 0.9 MAC or 1 MAC. Go a little bit higher on the concentration that you're administering. Similarly, if you're doing TIVA with propofol, use a slightly higher concentration than you would have done without the paralysis. Unfortunately, there is no fail-safe minimum anesthetic dose for everybody. So even though you can try to build in a cushion to your anesthetic administration, there is no fail-safe minimum. And I should also point out, although this is not the subject of what I'm talking to you about today, that there is a controversy about overdosing with general anesthesia. And increasingly, there is literature emerging that some susceptible patients might have deleterious effects if they get relatively too much general anesthesia. This is within the realm of early investigation, and there are no firm data on this, but emerging evidence suggests that at least this is an important theoretical consideration. So carrying on with the checklist of other important things to do, I mentioned setting the alarm for a low anesthetic concentration. Make this your practice. You go into the operating room, you're inducing your patient, you intubate, and one of the first things you do is you turn on your vaporizer, you set your alarm for a low anesthetic vapor concentration. Make it routine. You do it each and every time you set an alarm for low anesthetic concentration. And if you don't do it at 0.5 MAC or 0.7 MAC, do it at 0.2 MAC, so that at least you will detect if you forget to turn the vaporizer on. It's really, really important. And if a patient is hypotensive, there are other effective treatments besides turning off the anesthetic, which is what sometimes is the easiest thing to do. And the problem with turning off the anesthetic is that you sometimes forget to turn it on again, because hypotension usually occurs when there is a crisis in the operating room and you're focusing on the crisis and forgetting to turn on the anesthetic again. A brain monitor is a passion of mine, and I've mentioned that earlier. We should be monitoring the brain. It's not rocket science. An EEG, even if it's a single channel EEG, can be used inexpensively and provides valuable information. I see no reason why intraoperative EEG shouldn't be part of every general anesthetic, and that provides an extra safety cushion to you in the operating theatre. And certainly, if you're doing total intravenous anesthesia, where you cannot monitor in real time the concentration of anesthetic that you're administering, I think it is all the more imperative to use a brain monitor, an EEG-based brain monitor. This is an algorithm from a clinical commentary by me and George Mashur for the prevention of intraoperative awareness. And it doesn't really take everything that I've been talking about into account. For example, we're really summarizing the studies that have been done with patients who are largely pharmacologically paralyzed. But with that disclaimer, I'll quickly take you through it. If you're doing a general anesthetic for patients at high risk of intraoperative awareness, so for example, people who are chronic alcohol drinkers or take cocaine, or perhaps they've had a history of awareness in a previous operation, that puts them in a higher risk category. Ideally, you should try to use a potent volatile agent for all patients because it's associated with a lower incidence of intraoperative awareness. If you're not using a volatile agent, or if you're not going to be setting alarms for anesthetic concentration, you really should use a brain monitor like the bispectral index, but probably any other EEG-based monitor will be as efficacious. If you are using a volatile and you are setting alarms for low anesthetic concentration, that's probably going to be as good at decreasing intraoperative awareness than a brain monitor like the BIS would be. And Similarly, if even with the general population, those who are not at high risk for intraoperative awareness, if you're using total intravenous anesthesia, you should probably use a brain monitor like the BIS or any other raw or processed EEG-based monitor, because that will almost certainly decrease the incidence or the likelihood of intraoperative awareness.